Our third lecture in this session for Meeting the Experts in Breast Cancer will focus on the question, why are we so late using immune checkpoint inhibitors in breast cancer? The chair for this lecture is a recipient of many awards, including the Dr. B.C. Roy Award and the Padma Shri Award. He founded the Bangalore Institute of Oncology and is the director and a consultant surgical oncologist of the same institution. He has done extensive research on oncology with special emphasis on the surgery of head and neck, a comparative study of laparoscopic and conventional surgical methods, cancer of the rectum, and the impact of yoga on cancer. He was president of the Association of Surgeons of India in Chennai, the president of the Indian Association of Surgical Oncologists, the president of Ostomates India in Bangalore, the vice president of the Indian Society of Oncology, the chairman of the Association of Surgeons of India, Karnataka chapter, is a joint editor of the Indian Journal of Surgery, and a member of the governing council in the Association of Surgeons of India. Ladies and gentlemen, may I present to you Dr. Kodagnur Gopinath.
Good evening, ladies and gentlemen. It gives me a great pleasure to present to you this evening Professor Stefan Gluck. Professor Stefan Gluck is the Vice President of the Global Medical Affairs of Celgene Corporation, situated in New Jersey, United States. He is also the Medical Associate Editor of Breast Cancer Research and Treatment. He is the co-editor of the journal Carcinogenesis, which he co-founded in the year 2014. Professor Stefan Gluck held many academic positions during his last 4 to 5 decades of his career. He also holds the various academic positions in prestigious medical institutions. To name a few: Sylvester Professor, Department of Medicine, Miller School of Medicine, University of Miami. He was the director of Southern Alberta Breast Cancer Program at University of Calgary. Even in the University of Calgary and in Canada, he has held many positions and reached the chairman of the various divisions. He has a passion to get involved in clinical trials and translational research. For his outstanding contribution to academic and social community oncology, he has received in the year 2008 Top Oncologists of America from Consumer Research Cell. He was also awarded the Best Doctor in America from 2006 to 2014. Tonight, he will answer your questions. Why are we so late in using immune checkpoint inhibitors in breast cancer? Ladies and gentlemen, I will be presenting to you and welcome Professor Stefan Gluck. Thank you.
Hello, it's an extraordinary pleasure to give you a keynote lecture, which unfortunately is virtual. Initially, I was invited to give a lecture in Manila, in person, as I did 2003 and 2004. And I will show you a picture of 2004, where I met for the first time many of you, including Ding and Cherry, where we established a friendship. So it is a difficult time with the pandemic, and I really hope that very soon we can get back to almost normal, the new normal. And I don't think it will be completely the same as it was before. And we have learned that many of our activities, like this one, may be a little bit less important and less good than, let's say, in person, but can be educational and interesting as well. So let me get started to share the screen, to show you the data, and tell you why we are so late in treatment of breast cancer using immune checkpoint inhibitors with chemotherapy. Now, when I was in Manila, it was the first time I was a professor at the University of Calgary. The second time, 2004, I was professor actually at the University of Miami. In the meanwhile, I retired. But instead of retiring completely, I joined pharmaceutical industry, biotech industry, and more recently, Regeneron, building their new franchise in oncology. There's a number of very important events happening with Regeneron. The monoclonal antibody cocktail against Ebola virus was just approved by the FDA, and hopefully soon something for the SARS-CoV-2 virus. Let's hope. So what we are talking about today is what I did not talk about 16 years ago. We did not have any immunotherapy at that time. 2004, I had the privilege to join the Medical Society of the Philippines in the El Nido Resort on the island of Palawan. It's close to paradise, I only can say. And this is the team that we at that time had gathered together. Now, in the meanwhile, we learned something new. We learned how actually immunotherapy is different from all other cancer treatment until date. And Hervé Friedman gave me his slide, which is very simple and depicts the revolution, the new paradigm of treatment for cancer. We used to target the tumor cells with surgery, radiation, chemotherapy, biologics, small molecules, and so on and so forth, in order to reduce the tumor burden or even get rid of it and maybe improve quality and quantity of life of patients and maybe even cure patients. And sometimes it happened, sometimes it did not. The new paradigm is different. We do not target the cancer cell anymore. What we do is we are targeting the immune system to harness it with power and with the ability to kill only those cancer cells that we identify and the immune cells identify by itself. We don't have to do it. We just make sure that the immune system via exhaustion is reactivated and kills these cells itself. So it's the lymphocyte that we are targeting. Now, it's not so easy because there's a tumor microenvironment. The tumor core itself grows and grows once it's starting becoming a cancer cell. Then you know that the mutation in the genetic material of every cell can be changed, can be mutated. And if the mutation is not so bad that the cell dies and not so good that it can be repaired, somewhere in between, then of course we have the event of a malignancy, which means unlimited growth and infiltration into tissues. Now, there's a lot of happening with these cancer tumors in the tissue. First of all, it needs some nutrients, oxygen, proteins, sugars, and so on, and get rid of some toxins. So the new vessels, neoangiogenesis needs to happen. And we can target neoangiogenesis. The immune system is activated by dendritic cells, by macrophages, natural killer cells, and so forth and so forth. And they all need to come into the cancer area. Now, we also have some suppressor cells, such as MDSC, myeloid-derived suppressor cells, and Tregs, T regulatory cells. And there's a good mix of interaction between these cells in the tumor stroma, in the tumor bed, which again plays a major role. For example, cancers such as pancreatic and GBM, glioblastoma multiforme, they have such a stroma that it cannot be infiltrated by immunocells. And actually, even chemotherapy can hardly get into the cancer growing in the pancreas or in the brain. Now, how does the immune system work? And it's a simplified, but still very important cycle that we like to quote. It is 7 years old, adapted from Immunity many years ago. And if the tumors here depicted in gray are here, some of them will die either spontaneously because the tumor grows so fast or induced by chemotherapy. And these cells, as they are dying, can release proteins. And these proteins very often are not the same composition as normal cells of the same tissue, and they can be antigenic. So we call these proteins neoantigens, new antigens which can be antigenic or are antigenic and can be immunogenic. But immunogenic only then if the immune system is activated via the cancer presentation, cancer antigen presentation, number 2 in the cycle here. And you see that the dendritic cell, but also macrophages and also B cells can be such antigen-presenting cells. And they do one thing. They present this antigen to lymphocytes, usually sessile in the adjacent lymph node, and activate the dormant T cells into 3 areas, activating CTLs, cytotoxic lymphocytes, memory cells, and also Tregs, regulatory lymphocytes, which are negative, regulating the T cell function. Now, these T cells, once activated, CD25 positive, they usually migrate into vessels and traffic through the vessels, the blood vessels, into the tumor of origin, either the primary or the metastases. So these cells go in these areas and are called tumor-infiltrated lymphocytes. They infiltrate, number 5 here, into the tumor, and as they are active and recognize the initial antigen that they were primed for by the dendritic cell, they actually do what they're supposed to do. They attach to the tumor cell and can kill it. Now, a protein, which is called PD-1, is sitting on these lymphocytes and can be activated by PD-L1, which is released by tumor cells. So if the PD-L1 activates PD-1, the tumor cells stops doing what it's supposed to do. It stops killing. Now, it's important to prevent autoimmunity in other instances, but it's not important and not wished for in cancer. And what happens is that these tumor cells and this immune cycle goes all the way, as I just depicted, but sitting in the tumor doesn't do anything to the tumor cells. Similarly, another very important signal is under 3, prime inactivation. The CTLA4 protein is an activation protein, and only if the CTLA4 is not inhibited, then actually it activates. And there were 2 very wise scientists, Jim Allison, who discovered the CTLA4 axis, and Tasuku Honjo, who discovered the PD-1, PD-L1 axis, and have been recognized 2018 by the Nobel Prize in Physiology and Medicine. So why is it important? Well, it's important because these neoantigens are more prevalent in tumors that have more mutations. And this is another 7-year-old slide, which is still valid and shows a series of cancers, not all, of course, the prevalence of mutations, of the somatic mutations of these cancers. On the y-axis, you see the frequency in megabytes. So, for example, some of the rhabdomyoid and Ewing and other sarcomas and thyroid cancers and AML have below 1, actually 1/10 of a frequency of mutations per megabase. On the other extreme, we have melanoma and lung cancer, where you have 10, 100-fold such a mutation load. Some of the cancers go all the way up 100 and 1,000-fold. So this is a difference, and it usually depends on the reason why cancers arise. So patients who are exposed to cancerogens, such as UV light, such as smoking, such as viruses, they are on the right side of this curve, and they have melanoma, lung cancer, or bladder cancer. Hence, mutation rates are higher. And the others, where we sometimes don't know the whole story, they actually have less mutations. Breast cancer is somewhere in the middle, and breast cancer, as you of course know, is not a homogeneous disease, but more mutations, probably in the range of 5-fold more, and maybe even 10, depends, because it's a continuum, it's not just one thing. Triple negative breast cancer has more of those. Therefore, in triple negative breast cancer, it is anticipated there are more neoantigens and would be the better model for using immune checkpoint inhibitors in triple negative breast cancer than not. Additionally, triple negative breast cancer shows infiltration of these lymphocytes that I mentioned before in the tissue. Now, what we have seen in 2015, and this is already when immune checkpoint inhibitors were approved for melanoma and lung cancer, that Leisha Emmons from Johns Hopkins showed in a small phase 1 study using compound PD-L1 inhibition by MPDL3280A, which you and I know now better as atezolizumab, in an activity in triple negative breast cancer. Now, she used it on 21 patients who expressed PD-L1, and there were more patients, there were 55 patients in the study, but they did not express it. So here are the data of 21 patients. And you see that some patients had progression, some patients had initial progression and then a reduction on this spider plot. Some had partial remission in red, and some green, they had partial, good partial and long-lasting remission, or even a complete remission. Now, chemotherapy could potentially improve such a very modest response rate, in spite of the fact that some patients had long-lasting responses. And this is why we need to use more. So in breast cancer, the response rates on average using single compound immune checkpoint inhibition is about 10 to 15%. Now, in melanoma and gastric and lung cancer, it's more 20-25%. Colorectal, as long as it's MSI high, microsatellite unstable, then the response rate is as high as 30%. But everything more is not possible. And there are some cancers that actually don't respond at all to immune checkpoint inhibitors, exactly those that have low mutation tumor burden. And breast cancer being somewhere in the middle, it just asks for combination with something. Now we can use radiation, we can use other biologics, we can use hormones, but chemotherapy is the most and the only active compound or group of compounds in triple-negative breast cancer. Hence, the combination of chemotherapy with immune checkpoint inhibitors in triple-negative breast cancer. Now, I mentioned the infiltration by lymphocytes of the tissue. Left lower panel, you see a tissue HE staining with some brown, actually not some, many brown dots throughout. These are the lymphocytes that are doing exactly what they're supposed to do. But they may be inhibited by the PD-L1, at least those cancers that we know are positive. Now, we have non-functional immune responses where the immune cells, T cells, actually go, but do not infiltrate completely and stay marginally in areas which are less important and are not really active against these cancer cells, in spite of the fact that you can give them immune checkpoint inhibition, but they need to be there in the cancer. Now, there are some cancers, and I mentioned already pancreatic or GBM, these cells are not even infiltrated at all into the tissue. They stay somewhere outside, like in the panel on the middle right side. And now we have some where there is no reaction at all. And I mentioned some of them. These are usually cancers that have very, very low or no mutation burden. Now, chemotherapy by itself actually can do and induce something. If you look from the center to your right, it actually through even marginal cell kill can release these tumor antigens, these neoantigens, and therefore these can be presented. Hence, immunogenic cell death may happen. Now, this increase of antigen presentation, which goes through the dendritic cells, as I mentioned, can actually be upregulated through appropriate chemotherapy compounds, such as taxanes in a lower dose, but more frequently given, and can lead to epitope spreading. Now, some of the chemotherapy agents in a specific dose, and I mentioned already about the weekly dose, can actually release pro-inflammatory cytokines, such as interferon gamma, which is pro-immunogenic. We know it is actually a measure of immunogenicity, and IL-2 and IL-15. It actually can polarize Th1 and can also induce and increase the function of CTLs. Finally, in some instances, and these are all preclinical data, so it may or may not be true in clinics, but it's proven in some models. It can reduce Tregs, so that regulated T cells, which are suppressors, and the myeloid-derived suppressor cells, which by themselves, as the name already says, are immunosuppressive. Now, we use taxanes in breast cancer quite frequently, and we use paclitaxel, and docetaxel. And these are very good and effective compounds, at least for a period of time. The median time to progression in first-line treatment is about 2-3 months in triple-negative breast cancer, so very short-lived. And it's the best what we have in metastatic disease. And the response rates are, as a single compound, about 20-25%. So again, not too much. So we need, and it looks for better. Now, if you use nab-paclitaxel, actually the response rates are somewhat higher, 15-20% higher than solvent-based paclitaxel or docetaxel. And also, it is not only breast cancer, but also active in pancreatic cancer, interestingly enough in melanoma, and of course in lung cancer, non-small cell lung cancer. It has a well-characterized and acceptable toxicity profile, well known, especially in a weekly schedule, when you give 100 to 125 milligrams per meter squared, 2 out of 3 or 3 out of 4 weeks. The PK profile hints to accumulation of the paclitaxel compound itself in tumors, much more and higher than paclitaxel in the solvent phase. And finally, you do not need steroid premedication, which may downregulate antigen presentation and may inhibit the immune system function. Now, sometimes we want to do it. If the immune system is overflowing in autoimmune disease, we use steroids, but we don't want it in this instance. Therefore, it was tested by Sylvia Adams from NYU 2 years later or 1 year later, a combination of nab-paclitaxel with atezolizumab again. And in first line, you see only one patient actually progressing, and all the others, sure, it's only about a dozen of patients had minor or good partial response or a complete response. But it was long lasting, about a year. This is much more than we are used in chemotherapy use of in triple negative breast cancer. Even in second line, you have some patients not progressing. This is very rare in triple negative breast cancer. Everybody progresses sooner or later, rather sooner than later in second line. And some of these partial responses go here over a year. That's already very promising. Now, therefore, the company Roche and Genentech, they designed a study in patient 130, and it was presented by Peter Schmidt a couple of years ago at the ESMO meeting. And what this study is designed is basically the following. Only patients with metastatic or locally advanced triple negative breast cancer were enrolled. They must not have had any treatment for metastatic disease, hence it's first line. And if they had chemotherapy in an adjuvant setting, it must have been at least a year prior, and good performance status. They were stratified for taxane use, liver metastases, and PD-L1 status, positive or negative. And I mentioned how important it may be. Indeed, for this study, it was very important. And the patient received nab-paclitaxel in a dose of 100 milligrams per meter squared, 3 out of 4 weeks on a 4-weekly cycle on both arms, and either atezolizumab at 840 milligrams IV or placebo IV every 2 weeks. Co-primary endpoints were progression-free and overall survival, both in the IIT population and only in the PD-L1 positive subpopulation. Turns out the PD-L1 positive subpopulation was about 40% of all patients. 900 patients overall were enrolled. And to make the long story short, the IIT PFS is here. The HR is 80, so reduction of 20% with a p-value that is significant, with about 1.5 months difference in progression-free survival for chemo versus chemo with atezolizumab. More importantly, and that's what I mentioned before, if these tumors showed PD-L1 expression, and that's key here, and this expression was inhibited by atezolizumab, then you have here 2.5 months delta. The curves separate beautifully and pretty for a long time, up to 2 years. The p-value is highly significant, and the HR is 62. So 40% almost of all recurrences and progressions can be reduced. Now, this does translate into overall survival, and here in the interim analysis, and in the meanwhile, we have the full analysis, you see the HR of 62, and you see the overall survival with chemo alone is about 15.5, and with the combination 25 months, not quite 10 months advantage of survival using both together, chemotherapy and immune checkpoint inhibitor, PD-L1 monoclonal antibody, atezolizumab. Subsets, all the subsets benefit. Everything is on the same side, on a side in favor of the combination versus not. Responses are important, at least in patients that have symptoms. So if you reduce the size of the tumors, particularly if they induce severe symptoms, then you improve quality of life and satisfaction for the patient. So responses are important. And many of the triple negative cancers are inducing symptoms. So we have in the IIT population 46 versus 56, so 10% improvement. In the L positive, PD-L1 positive subpopulation, 43 versus 59, 16% more patients have a response rate. Not quite, but almost 2/3. Side effects, interesting enough, not much differences except what you would expect. Hepatitis, pneumonitis are slightly higher, not very much higher in the combination arm. But the only real problem here, and it's easily monitored and easily treated, is hypo and hyperthyroidism, which is different and significantly more in the combination arm of nab-paclitaxel together with atezolizumab. So overall, not much different. Now, there is some difference also in the rash, 26 versus 34%, but other than this, more or less the same, 1, 2, 3%. No big differences. So I would like to summarize. immuno-oncology using immune checkpoint inhibitors alone, somewhat, and in combination with chemotherapy. And there are other examples. There's breast cancer. In combination, there is melanoma, and of course, lung cancer and other cancers actually have revolutionized oncology in our treatments and improved patients' outcome. We see in some studies plateaus, long-term plateaus in OS, which means patients may be, fingers crossed, be cured, at least some of them. And finally, we have something for breast cancer, and obviously the drug was approved. It's called Tecentriq, and you can use it in many countries across the globe. Now, it is not enough, and therefore, I think combinations are really looking and coming into our treatment armamentarium. I showed you the combination ICI with chemo, other immune checkpoint inhibitors, such as CTLA-4 inhibitors. In lung cancer first line, we see it for the first time. Nivolumab and ipilimumab is not only highly functional, but also approved now. No chemotherapy. And in melanoma, we had it for a couple of years. So indeed, these can be additive or maybe even synergistic. Radiation may also lead to improvement of outcomes and obviously targeted agent as well. But there are new challenges. What to do with non-immunogenic tumors? And there are some answers and some proof of concept studies already out there. What should we do with resistance? How can we reverse resistance? And there are, again, a number of compounds which can reduce the ICI resistance. We need to learn how to treat, recognize and treat the novel side effects. And we have to learn some of the new endpoints for clinical trials. So what we discussed and discovered in lung cancer is a so-called false progression or pseudo-progression. So tumors seem on a scan to be bigger for now after the first scan and then shrink. They are actually bigger by scanning, but not by biology. The cancers attract many, many more immunogenic cells, T lymphocytes, macrophages, even neutrophils. So it looks like it's bigger. It is bigger as a tumor, but not as a cancer. So we need to learn these things, how to deal with it. So I would like to end with a promise. In the past, before treatments, the yellow curve indicates how stage 4 cancers are ending up. Sooner or later, everybody progresses and will unfortunately die. Now with chemotherapy, we can delay it somewhat. And there will be a few, 1, 2, 4% long-term survivors. With immune checkpoint blockade that you have seen very often in melanoma and in lung cancer now, there are two compounds, there are single compounds effective in lung cancer, cemiplimab and pembrolizumab. They actually can lead for long-term outcomes, positive, and maybe cures, even alone, but not enough patients benefit. So the combinations with immunotherapy and other treatments, which is the dotted line in black, is probably where we are at right now. Now, what we need to do, we need to learn much better which patients and tumors to target, for example, MSI high, for example, high tumor burden, and then we can actually show even more patients responding, more patients surviving longer, and some of them being cured. Thank you very much for your attention.